Over the next 15 minutes, I'd like to provide you with an overview of mechanical circulatory support to provide a framework on how you think about the different support options. The title was graciously provided by the organizers, and I thought it was quite appropriate to mechanical circulatory support in 2017. So I have no conflicts of interest to disclose. In 2017, mechanical circulatory support is really trying to follow the rabbit down the hole. There are many options, including ECMO, tandem heart you see in the lower left-hand side, Impella as short-term options, Centromag biventricular cannulation for temporary support, and then destination therapy or bridge to transplant or other more durable indications with HeartMate 2 and HeartWare and now HeartMate 3. And so with all of these different options on the table and other emerging options, it becomes very confusing for practitioners in the area of advanced heart failure on what to use. And sometimes we end up like this, confused with our head in the sand. And so the whole point of this session is for you to be able to select appropriate treatment strategies for rapidly progressive heart failure, develop strategies for indolent advanced heart failure with regard to durable mechanical circulatory support, and to effectively employ the use of temporary support or the use of durable support in those with advanced heart failure. The first thing I think we need to do in considering these patients with advanced heart failure are identify what level of patient profile they fit in. The Interagency Registry for Mechanically Assisted Circulatory Support, INTERMACS, has provided us with 7 different patient profiles from 1 to 7. 1 being the crashing and burning patient, the patient in critical cardiogenic shock, sometimes patients who've been having CPR and who are in the phases of recovery. But essentially, these patients are on death's doorstep. And so they typically, if they're candidates, need mechanical circulatory support within hours or even shorter. They are a distinct group of patients compared to those in levels 2, 3, or 4. Level 2 is progressively declining patients, patients sliding on inotropes with continued deterioration, versus level 3, stable but inotrope dependent, and we've all treated those patients in our critical care units. They're inotrope dependent with end organ dysfunction without the use of inotropes. And then there's level 4, recurrent advanced heart failure, patients who have recurrent rather than being refractory in decompensation, who have protracted heart failure episodes that require repeat hospitalizations. These patients are also considered for mechanical circulatory support. And then there are status 5 and 6, who are exertion intolerant or exertion limited. Their use of mechanical circulatory support is somewhat variable and debatable. Sorry, let me go back. And then there's 7 at the end, advanced NYHA class 3. Patients are clinically stable with a reasonable level of comfortable activity despite the history of previous decompensation. Although they're not candidates for MCS, it's good to list them as profile 7 because they may eventually slide down 6, 5, 4, 3, 2, and 1. And so once we develop a framework for where patients lie along this patient profile listing, we can think about mechanical options and the timing of which mechanical options should be considered. The second step is to consider the different goals of mechanical circulatory support. Today, there are 5 different categories patients typically fall into when we consider them for mechanical support. They're either bridge to decision or bridge to bridge, and I'll discuss each of these in more detail in the upcoming slides. Bridge to candidacy, in other words, candidacy for either destination therapy or transplantation. Bridge to transplantation, destination therapy, which I'll outline shortly, and bridge to recovery. Bridge to recovery involves a small fraction of patients with particular conditions that I'll elaborate on. So in terms of bridge to decision or bridge to bridge, these are usually the patients in profile 1 who are in cardiogenic shock with very poor hemodynamics and evidence of profound end organ perfusion, either profound liver dysfunction, kidney dysfunction, etc. And they may have contraindications currently for long-term mechanical circulatory support or transplant. Sometimes these are patients who have uncertain neurologic prognosis following resuscitation. And in these patients, we describe using mechanical circulatory support as a bridge to decision, a way to resuscitate them to the point where we can make these decisions to see whether or not their end organs recover and they have neurologic function intact. And usually, these patients are considered for short-term temporary mechanical support. And that often is in the form of ECMO. As you can see here, ECMO is a version of the heart-lung machine we use in the operating room that's been pared down without the use of a venous reservoir. And it has distinct advantages in patients who are critically ill. It can be instituted very quickly. It can be instituted at the bedside in some cases, and it provides immediate total cardiac and pulmonary support. It has an oxygenator in line, and so it basically is the way to treat patients who are critically ill and often on the verge of CPR or having just recovered from CPR. And in fact, we can cannulate patients who are undergoing CPR in the form of ECLS. These patients require a venous drainage cannula and an arterial cannula, and as you can see with the arrow, an antegrade sheath. That antegrade sheath is a more recent development, and it's from our experience with limb ischemia. Once we use an antegrade sheath to perfuse down the leg, excuse me, the incidence of peripheral limb ischemia has gone down, not to zero, but has gone down pretty dramatically. The other alternative temporary support to provide total biventricular support, either with or without an oxygenator, is BIVAD support. BIVAD support provides you with essentially the same type of support ECMO would, up to 10 liters of flow, depending upon the cannula sizes, but it has the distinct disadvantage being that it involves a sternotomy. In the patients who have profound liver dysfunction, who are coagulopathic or have been loaded with antiplatelet agents, the thought of doing a sternotomy and avoiding major bleeding complications in this scenario is fraught with dangers. And so unless the patient has been bridged with ECMO to the point where they're no longer coagulopathic and no longer in liver failure, biventricular support is used for the somewhat more stable patient, usually profile 2 patients or higher. The other options that are available today that are percutaneous are the Impella you see on the left-hand side. That's inserted through an arterial puncture in the groin. The Impella CP device can provide up to 3.5 liters of flow to resuscitate patients or provide a left-sided support for high-risk PCI or other interventions, and is quite effective for univentricular support on the left side. The right-sided devices are being developed and are on the verge of being clinically used outside of clinical trials, but essentially Impella CP and Impella and other versions has been used for left-sided support. On the right-hand side, you see Tandem Heart, which we just started using at the Toronto General Hospital. It provides up to 5 liters of flow, and it is entirely percutaneous. A cannula is placed through the venous system, and a transeptal puncture is performed such that the drainage cannula lies in the left atrium, and it provides outflow through a peripheral arterial outflow cannula. And again, this is used for left-sided support. There is a right-sided device that is available, again, for right-sided univentricular support, but it's limited by the level of support you can provide. It does not provide you with entirely high levels of support. It provides you with enough to get through procedures or to get the critically ill patient temporary support. In terms of bridge to candidacy, patients who are currently ineligible for heart transplant due to a variety of reasons such as end organ dysfunction, pulmonary hypertension, or other social issues that need to be sorted out that preclude transplant candidacy can be considered for mechanical circulatory support, and usually these patients are considered for durable LVAD therapy to allow for the opportunity for anticipated future candidacy. And so there are a number of patients who we support this way. Some of them end up being transplant candidates, some of them do not, in which case they go down the pathway of what I'll describe next, which is destination therapy. Bridge to transplantation, these are clearly patients who are at high risk of dying while listed for heart transplantation. They may slide up the status listing from status 1 heart transplant listing to 2, and if they become hospitalized and end up in the CCU on inotropes, becoming intermax profile 2 or 3 patients, and sometimes we will intervene with either a durable LVAD or in some cases biventricular support in a more elective fashion. Destination therapy is the term we used for treating patients with end-stage heart failure who are ineligible for transplantation. they can be considered for durable LVAD therapy. And I put considered in italics because not every patient out there is a candidate for destination therapy. We have to be very selective about who we choose for destination therapy, and that will become obvious when I discuss some of the limitations of LVAD therapy. And this is entirely as an alternative to transplantation. So what we tell patients is that, unfortunately, you're not a candidate for transplantation, but we're going to put an LVAD in you for as long as it's able to provide support and improve your quality of life. And more patients around the world are being given LVADs for destination therapy. And in fact, about a half of the LVADs put in America at least, are being used for this indication. Bridge to recovery, this is for patients who have profound and severe cardiac dysfunction that may be reversible. Some of these patients present with acute fulminant myocarditis, postpartum cardiomyopathies, etc. They can be considered for mechanical circulatory support, sometimes in the first instance being ECMO and then being bridged to other more durable levels of support. When patients recover, we have explanted devices or taken them off support from time to time. Current long-term mechanical circulatory support options. So some of you may remember these images. On the left is the HeartMate XVE. On the right is the Novacor devices. As you can see from this torso model, these devices were huge, clunky, loud, have lots of parts that wear out. They had valves in them, and that's the past. We no longer use these devices. Now we have much less traumatic devices to put in that are much more durable. We have the HeartMate 2, which has been on the market for both bridge to transplant and destination therapy. It provides up to 10 liters of flow. The HeartWare device is a completely intrapericardially implanted device. Again, can provide up to 10 liters of flow. And now we were the first in Canada to place the HeartMate 3, a completely magnetically levitated device with larger blood gaps, completely intrapericardial, again, providing 10 liters of flow. And there are a number of devices in the pipeline that are smaller and thought to be more durable. In terms of long-term mechanical support, as I alluded to before, these are patients with advanced heart failure, stage Z heart failure. They usually fit into the InterMax profile 2 to 4, as I mentioned previously. These are clearly not the patients who are crashing and burning. The InterMax 1, we've gone through the history of trying to put these devices in these patients, and the outcomes are suboptimal. And so the strategy has now been divided into short-term temporary devices and long-term devices. These longer-term devices should be reserved for patients who either are InterMax profile 2 to 4 to begin with, or who are put into that position through the use of short-term devices. In terms of the outcomes of long-term mechanical circulatory support devices in bridge to transplant patients, as you can see from this paper from 2001, more than 15 years ago, we realized that compared to medically managed patients, there's a dramatic improvement in survival with patients who are bridged with mechanical devices to transplant. Compared to medical therapy, you see in the left-hand graph, and with the newer generation devices, the results, as you'll see, have been improved. This is an example of a patient. This is Andrew Jones from the United States. He's a bodybuilder, and you can see that these patients who are bridged, this man was bridged to transplantation. He had a HeartWare device in. They go back and they recover. They're no longer ICU bound. They're no longer inotrope dependent. They're no longer in renal failure. They go back to normal levels of activities. And to take this patient compared to someone who's dying in the CCU to transplantation is a much better option. And the results of patients who are bridged in this way have continued to improve. This graph from the InterMax registry looking at 15,000 patients shows you that at 2 years, in fact, 24 months, only 13% of patients are dead. The vast majority are either alive or transplanted. And so that goes to show the impact that mechanical circulatory support has provided in those patients who are bridged to transplantation. As our experience continues with using the device, in the more recent era, 2012 to 2014, compared to the previous era, you can see that the survival curve is continuing to improve. The devices have changed, as I've talked about. The HeartMate 2 trial compared to the pulsatile flow XVE device to the continuous flow HeartMate 2 device you see in the right-hand panel. And you can see there's been an incremental improvement in survival with the continuous flow devices. And so as technology continues to improve, our outcomes continue to improve. And when you compare that to, again, the historical rematch patients, the medical arm, you can see there's a dramatic improvement in survival out to 2 years, even in the patients with destination therapy. And again, in the more recent era, the survival curves continue to diverge, and destination therapy patients are surviving following this therapy. In terms of limitations of mechanical circulatory support devices, we have to consider the valves. Patients with more than mild aortic insufficiency need to have this addressed. Mitral stenosis needs to be addressed because it'll impede the inflow of the VAD. Severe TR is usually corrected, moderate sometimes, and mechanical valves usually need to be replaced or patched. And so there are specific valvular and intracardiac shunt issues. All intracardiac shunts need to be repaired. So it may not be just a VAD. We also have to consider the other intracardiac lesions to be repaired. RV dysfunction is a very important topic to consider, especially in patients with destination therapy VADs as the indication. For bridge patients, if they have RV failure, we can always put in a temporary device to support them to their transplant. But in DT patients, it's a challenge because a long-term dedicated implantable RVAD does not exist. So it is a major problem. We can predict RV failure posting LVAD using a number of indicators like RV stroke work index, pulmonary artery pulsatility index, RA to pulmonary capillary wedge pressure. Nothing's perfect, but we do have tools that we can use. In terms of outcomes after VADs, in terms of complications, there are neurologic complications, infection complications, device malfunction, and right heart failure, as indicated by that graph. Over time, bleeding complications have improved, infection, stroke, and renal dysfunction have improved, and more importantly, hypertension has improved dramatically because we've recognized in these patients hypertension is a predictor or a correlate to neurologic events. And so these patients need to be meticulously followed, and hypertension is to be avoided. And so we've recognized that in the mechanical circulatory support community and have addressed this dramatically. But at the end of the day, these patients have neurologic events, multi-organ failure, withdrawal of support, major infection as the leading causes for death postoperatively. And as you can see, as each month goes by, eventually these patients have some sort of infection, bleeding, malfunction, stroke, or death, unfortunately. So it's not the perfect alternative to transplantation yet, but it is what we can use to provide dramatic improvement in patients. So to close, I hope that you now understand the Intermax patient profile as a guide to timing and type of MCS to consider. Long-term MCS is indicated in Intermax 2 to 4 patients and not the level 1 patients. It does clearly improve survival of patients as a bridge to transplant and in DT-eligible patients. And unfortunately, that bleeding, stroke, and infection complication limits the efficacy of long-term mechanical circulatory support. Thank you.